Hello, this is Timothy O'Brien. I'm from MetroHealth Medical Center, and I'm doing the CaseMed Minute. We first will discuss the differences between disseminated intravascular coagulation, or DIC, versus thrombotic thrombocytopenic purpura, or TTP. So again, we'll be talking about DIC versus TTP. So DIC, or disseminated intravascular coagulation, is a syndrome. It's an end-stage finding. There aren't specific criteria for it. The pathophysiology for DIC differs from TTP, and if you can't remember all of these little facts, try to remember the underlying pathophysiology, and the rest kind of flows from there. So DIC is due to endothelial cell damage, and endothelial cell damage results in tissue factor release and thrombin generation. With that, there's diffuse intravascular fibrin deposition with consumption of platelets and clotting factors. And the clotting factors being consumed is the bottom line. That's what you should remember the most, and that's what differs from TTP. With the result of clotting factors being used up, the clots that are seen are fibrin-rich, not platelet-rich. They're fibrin-rich. And so these patients have both profuse bleeding and or clotting. In the same patient, you may have both. Or in one patient, you may have just extreme bleeding or clotting. They have low platelet count because they're using up platelets in the clots in the microcirculation, as opposed to TTP, which we'll talk about. The clotting times, the prothrombin time, and the APTT, or activated partial thromboplastin time, are prolonged usually. The fibrinogen, which if you go back to the clotting cascade, is at the end of the clotting cascade, the bottom of it rather, is low because clotting factors are used up, so this is chewed up. And with fibrinogen being used up, you get the product of fibrinogen being activated, fibrin being used up, and you get fibrin split products being increased. You also get increased D-dimers. And on the peripheral blood smear, you'll see schistocytes. Schistocytes are fragmented red blood cells. The term for fragmented red blood cells, the slang is MAHA, or microangiopathic hemolytic anemia. This is not specific for DIC, and in DIC, there generally is less MAHA than there is with TTP. The treatment is easier said than done. It's to treat the underlying cause. So this is somebody who has DIC, or disseminated intravascular coagulation, and you can see here the patient is bleeding into their arm, but they also have dusky cyanotic feet. They're clotting as well, and that's DIC. The cause is most common that you'll see infection on the wards, usually gram-negative rods, but meningococcus can do this. Clostridia can definitely do it. We also see it with certain cancers. The malignancies most commonly associated are adenocarcinomas, mucinous adenocarcinomas, like pancreatic cancer or stomach cancer, but all kinds of malignancies can do this. The pathophysiology there is a bit different, and these patients wind up getting activation of factor 10, and with that, they tend to clot out of proportion to bleed. Obstetrical complications are notorious for causing DIC. Septic abortion, amniotic fluid embolism can do this, as can retained dead fetus. Also, widespread tissue damage from a dissecting aortic aneurysm can do this, and snake envenomation is notorious for causing tissue damage, endothelial cell injury, tissue factor release, and the whole DIC cascade gets set off. And this is a western diamondback rattlesnake. So snake envenomation can cause DIC. So that's DIC in a nutshell. Thrombotic thrombocytopenic purpura, or TTP, on the other hand, is due to antibodies to von Willebrand factor multimer cleaving enzyme. And this enzyme is called ADAMTS13. I'll get into in a minute. This stands for a disintegrin and metalloprotease with thrombospondylin motif type 13. And antibodies against this cleaving enzyme result in platelet-rich microthrombi. I'll go over that in more detail on the drawing board in a second here. But the bottom line is that results in platelet-rich microthrombi as opposed to clotting factor or fibrin-rich microthrombi. And that's how this differs from DIC. That's the most important thing to remember in distinguishing the pathophysiology of these two disorders. And because of that, the clotting times in TTP are usually normal. So the PT and PTT are usually normal. Fibrinogen is usually normal. The D-dimers may be slightly up non-specifically because clots are formed, but the other clotting times are usually normal. The clinical findings with TTP, the mnemonic is fat RN, it's fever, microangiopathic hemolytic anemia, thrombocytopenia, renal dysfunction, and neurologic deficits. By definition, they just have to have these two, the MAHA, microangiopathic hemolytic anemia, and thrombocytopenia. So the MAHA means fragmented red cells in the peripheral blood smear. So you see fragmented red cells on the smear. They have to have MAHA and thrombocytopenia without any other cause. They don't have to have all 5 of this pentad. In fact, in one series, only 40% at all 5. If you wait for all 5, the patient may die. So you don't wait for all 5 is the bottom line. You have to look at the smear to make this diagnosis because they will have, by definition, MAHA. The most important take-home message for TTP is without treatment, the mortality rate is sky high. It's 90%. In some older series, it was close to 100%. Generally young people, often young women, and they die within a day or two. The treatment is dramatic. It's called plasma exchange, in which you're pulling off a patient's plasma and exchanging, giving them someone else's plasma. That works in over 80% of patients. So it's maybe the most dramatic disease in all of medicine. The reason plasma exchange works, we didn't know this when it was first developed in the 1980s, is because we now know you're pulling off antibodies to this cleaving enzyme and giving them back someone else's plasma, which contains ADAMTS. This is to scare you what happens if TTP is not managed correctly. So really, really frightening disease, highly treatable and curable with plasma exchange. Also steroids. Steroids work because this isn't generally an acquired autoimmune disorder in which you develop antibodies against ADAMTS, and so steroids reduce antibody production, so that's why steroids are effective here. Just to go over in a little more detail how the pathophysiology of TTP works, just a real simple picture here. So this is a platelet. This is not what a platelet actually looks like. Think of a platelet as a boat. It sticks to sites of endothelial cell damage, and it binds there by von Willebrand factor. That's what von Willebrand factor's function is. Its other functions, it's a carrier protein for factor VIII. Well, it turns out that if you have really large von Willebrand factors, they stick together. One of the largest molecules in the body. And these are actually called, I kid you not, unusually large von Willebrand factor multimers. When these become very large, they actually cause platelets to clump in the circulation. And the platelets form a big mass, and it'll cause a clot in the microcirculation. So that's what happens if you have too much of these multimers. The reason we have these multimers is in states of high shear stress in the arterial circulation. It's important if you have endothelial damage for platelets to be able to stick there without flying away. So that's why we develop these multimers. But if you have too many multimers, you're going to get platelets clumping and you'll get clots in your microcirculation. And so we have evolved to develop an enzyme which breaks this, and that's called ADAMTS. We didn't used to call it that. It's a multimer cleaving enzyme. If you are lacking ADAMTS, then you can't cleave these multimers, and so all of this happens. You get platelets accumulating in the microcirculation, and you get clots in your arterial circulation, and you get TTP. So if we have antibodies against that, you get TTP. And that's how TTP happens. And again, you're not really using any or very little in the way of clotting factors. So your clotting times at PT and PTT are usually normal, whereas your other findings are pretty much the same, DIC versus TTP. So that is, in simple 5-minute terms, the difference between TTP and DIC.